Hello everyone, welcome to another educational video. Today we'll briefly explore how your GP or primary care clinician would approach a presentation of blood in the urine. We will discuss 3 clinical scenarios. Our goal is to provide valuable information to clinicians and patients experiencing these symptoms. A 43-year-old woman came for a follow-up clinic visit due to persistent microscopic hematuria. She had previously received treatment for lower abdominal pain after being diagnosed with pelvic inflammatory disease. At the 2-month follow-up, a repeat urinalysis test was positive for blood in her urine. How would you discuss her urinalysis results with her? In the second scenario, there's a 71-year-old female who has persistent microscopic hematuria. She has been experiencing dysuria and stress incontinence for the past year, but there has been no visible hematuria. This is her first presentation. Dysuria is characterized by burning or discomfort in the urethra while urinating. In the third scenario, a 68-year-old male with frank hematuria with associated mild dysuria and frequency during the night. This is his first appointment. What is hematuria? This simply means blood in the urine. Blood in the urine can be visible or non-visible to the naked eye. It's important to make a distinction between the two because they represent varied predictive risks in terms of serious illness. A simple urine dipstick can help you identify non-visible hematuria. In the absence of symptoms, there is little predictive value in randomly doing a urine dipstick. In the presence of urinary symptoms, common reasons for doing a urinalysis may include when you suspect UTI in a child with atypical symptoms. It has little value in adults unless there are certain situations like suspected renal colic, ongoing urinary symptoms with a negative urine culture and sensitivity, or other circumstances like in pregnancy. Furthermore, although a very small number of patients under 45 years could get bladder cancer, you should not ignore non-visible hematuria in anyone. Be prepared to investigate appropriately, including taking history and method of urine collection to avoid contamination from menstruation, time of intercourse, checking kidney function, urine albumin-creatine ratio, blood pressure, and renal imaging as required. To rule out menstruation as the cause of asymptomatic non-visible hematuria in women, check if it occurs within 2 days before starting menstruation, within a week after finishing a period, or more than 48 hours after sexual intercourse. In case these conditions apply, it's recommended to repeat the urine dipstick test to confirm. If a person under 60 years of age has persistent non-visible hematuria, as indicated by more than 2 pluses of non-visible hematuria in 2 out of 3 dipsticks 1 week apart, it is recommended to undergo certain tests to screen for chronic kidney disease. These tests include a full blood count to check for anemia, an estimated glomerular filtration rate, eGFR, and a urine albumin-creatinine ratio. Additionally, it is important to monitor the person's blood pressure, which should not exceed 140/90 mm mercury. Renal ultrasound should be offered to exclude structural or parenchymal kidney abnormalities such as renal stones, polycystic kidneys, etc. If the patient is older than 60 years old, this is an urgent referral or 2 weeks wait referral to exclude urological cancer. It is important to communicate the rationale and make patients aware of what to expect. This might include further imaging or procedures like cystoscopies, which is a camera test to visually examine the urinary tract. If the patient does not meet the 2-week wait criteria, then a routine referral to a kidney specialist, nephrologist, to explore further possibilities like the different glomerulopathies is recommended. Your GP or primary care clinician would refer to a 2-week wait hematuria clinic if the patient is aged 45 and over and has unexplained visible hematuria without urinary tract infection or visible hematuria that persists or recurs after successful treatment of urinary tract infection. Similarly, if the patient is aged 60 and over and has unexplained non-visible hematuria with dysuria or raised white cell count on a blood test. Bear in mind that unexplained hematuria refers to patients who do not currently have conditions that can cause hematuria, for example, urinary stone disease and UTI. Let's review the cases we started with. In the 43-year-old, the urine sample was collected appropriately, her physical exam was unremarkable, BP was 135/85 mm mercury, and her urine was sent for culture and sensitivity. Subsequently, request an up-to-date renal function blood test and urine albumin-creatinine ratio. At follow-up, her eGFR was 53 with urine albumin-creatinine ratio less than 3. She would benefit from a referral for an ultrasound scan of the abdomen with emphasis on the kidney, urethra, and bladder. If at a follow-up, she remains asymptomatic and the renal scan was normal, she should be referred to nephrology for follow-up to investigate glomerulopathies. For a 71-year-old female with persistent microscopic hematuria, she presented with 1-year history of dysuria and stress incontinence with no visible hematuria. Her physical examination was unremarkable, she was menopausal and had not had any sexual intercourse before urine testing. Her urine microscopy, culture and sensitivity were negative, and a repeat urine dipstick 1 week later remained positive for blood. She was referred urgently to urologists to exclude bladder cancer. In the last scenario, a 68-year-old man presented with visible blood in their urine, indicating a urinary tract infection, UTI, with a possibility of underlying sinister causes. During a physical examination, a smooth enlarged prostate was discovered, and the patient was given empirical treatment for UTI while waiting for urine culture results. The patient's blood in urine stopped after 3 days, and dysuria also disappeared. The urine microscopy, culture, and sensitivity was negative for any bacteria. 1 week after UTI treatment, the patient's urinalysis returned to normal. The patient was re-examined at a 4-week follow-up, and a blood test for prostate-specific antigen, PSA, levels showed a reading of 4.5. They were advised to book another PSA test in 6 weeks and complete an International Prostate Symptoms Score, IPSS, in readiness for a follow-up appointment after the second PSA test. The patient's levels remained at 4.4 with mildly symptomatic, lower urinary tract symptoms. He was diagnosed with benign prostatic hyperplasia, which could be managed conservatively in primary care. I hope these examples have been useful. Don't forget to like, share, and subscribe to the channel for more primary care learning.